Can we have the presenter on stage, please? Professor Dim, please come. We are running late, please. We're 2 hours behind. Like I said earlier on, this is one of the highlights of the Sogon conference. The pity we are starting very late. It's one of those events where we are able to come in because we are honoring a past president who is late. And like I said earlier on, we have 3 memorial lectures, the Losin, the Ojo, and the Organ lectures. We rotate them. So due to a lot of logistic reasons, we are starting a little bit late. So I'll hand over to the chairman of this session so we can go ahead with the presentation.
What do you say? Okay, yeah.
Just keep tapping it so it doesn't disappear.
Good morning, everyone, and you are welcome to this occasion. The Vice President too, Professor Aimaku, and co-chair of this session, the Secretary General, Professor Asibuke Oyebuchi, and other members of Executive present. I can see past President Professor Akinola, senior members of Sogon, Dr. Joseph Akide, former chairman of Lagos sector, Professor Layemi, and other discrete members of Sogon. Well, as part of our tradition, we usually organize a lecture for some of our past presidents, in terms of Professor Organ, Professor Ojo, and Professor Lossing. Today, specifically for Professor Organ, and to deliver a lecture with Dr. Dim Sirene. Well, just as a soft introduction to Professor Organ, Professor Organ, Okoronko Kesendu Organ, popularly called OK Organ, was an illustrious son of Nigeria. He was a very distinguished and revered physician and gynecologist. Actually, he was the first Nigerian gynecologist, and because he was educated in London, West Medical School, and University of London Medical School, he had his secondary education somewhere in Methodist in Nigeria, went to King's College too. When he finished his medical education, special education, came back to Nigeria and worked at Federal Ministry of Health. Later, he joined the University of Nigeria, the first head and first professor of gynecology. He was a foundation member of the then Nigerian Medical Council, now known as Medical and Data Council of Nigeria. He was appointed chairman Federal Service Commission in 1975, and he was for several years the head of the department, like I said, of Department of Obstetrics and Gynecology, University of Nigeria, Nsukka. He hails from Abia State, and he has contributed immensely to development, training of gynecologists all over the world, particularly in Nigeria, and has led an impactful position as the president of the first president of Sogon between 1965 and 1967. Now, the topic for discussion for today is advancing the African regional framework for cervical cancer elimination in Nigeria, enhancing routine HPV immunization, and defining the next steps. to give that lecture is no other person than our own Professor Dean Cyril, a distinguished obstetrician and gynecologist, an examiner, a trainer, and an elder scholar. So I now call on Dr. Dean Cyril to stand up and deliver his lecture. And I'm sure we are ready for an exciting lecture to be delivered by Professor Dean Cyril. You are welcome.
Yeah, thank you, the chairman of the session and the VP1 of SOGON, council members here, SOGON members. My name is Cyril Dean, and my affiliations are shown. My citations are in the brochure you have. I have nothing to declare, except that I've been speaking about cervical cancer elimination for a long time. I just pray I won't bore you. I wish to express my profound gratitude to the president of SOGON, Professor O.C. Beze, and the entire council of SOGON for granting me the honor of delivering this year's Organ Memorial Lecture. This honor is particularly significant because I'm happy to now join 3 top orgas that worked in my institution, highlighted. And my family and I are deeply appreciate this recognition. As a staunch advocate for global elimination of cervical cancer, I was immediately drawn to this critical area of women's health when asked to select the lecture title. I belong to the committee shown on the right. We reviewed the document you saw on your left, which is the document used for cervical cancer elimination globally now. Afterwards, we were encouraged to advocate for the implementation as much as we could. I did my best, and I'm happy that Nigeria is making some progress. Here, I was mobilizing the Nigerian Health Commissioners Forum members some years back. Here, I was mobilizing the Catholic Bishops' Conference of Nigeria some years back. Here, I took my campaign to a national television with Philip, who was the then SecGen. And there were many of these advocacy visits and drives. Now, for the first time, to the best of my knowledge, Organ Memorial Lecture will be dedicated to cervical cancer, a preventable gynecological cancer. In this lecture, I will share my perspective on the way forward now that Nigeria has started routine HPV immunization. The chairman has said a lot about Organ, so I will just highlight a few and move on. He didn't tell us he was a wonderful sportsman. He was the soccer captain in his time. He was the first gynecologist in Nigeria, the first lecturer consultant employed by UCH as a gynecologist. Well, I wonder if he's alive now, whether he would like to work in the Federal Civil Service Commission. We valued Professor Organ so much, and that's why our labor ward at the UNTH has always been named after him. According to Professor Vincent Egwatu, another Organ Memorial lecturer, in 2002, he described Organ as a gentleman of impeccable manners and amiable disposition. He always expressed his thoughts, views, and feelings unapologetically, and so on and so forth. In fact, when I looked at this consideration, there was a lot of migration, transmigration in Igbo land in the old. There's a town that came from my town. The orgies in Arondizog are dims. So I started wondering that Professor Gan must have been a very distant uncle I didn't know. If you know. So Professor Gan was described as a citizen of the world, an affectionate husband and father, a hardworking man who expressed unconditional love to his Item community, friends, and everyone who came across him. So now to our discussion. For today's lecture, I will use a lot of images. This is an adult class. Images and figures just to sustain your attention, okay? So I plead with you to just look at the slides and listen to me. This lecture centers on the cervix. The pictures you are seeing shows the location of the cervix. I'm sure most of us are gynecologists, so I won't bore us. The one you are seeing now shows a diseased cervix, likely to be cancer. The one on the left is obviously advanced, and that is what the world is struggling to eliminate. By way of burden of cervical cancer, globally, the number of new cases is about 660,000 per year. This is a 2022 data, and that's the most current. Globally, it's the fourth most common cancer in women, the second in sub-Saharan Africa among women, and the second in Nigeria among women, second to breast cancer. WHO director to make this statement some years back, where a woman dies of cervical cancer every 2 minutes. This suggests that this lecture was allotted 1 hour, which I'm not going to exhaust. But if I'm going to exhaust it, that means the next 60 minutes, 120 women will have died of cervical cancer. 108 of them will die from low and middle income country, and about 26 of them will have died in Africa. I think we should worry about this. With respect to incidence, the more blue the allocation, that means the darker the blue, the higher the incidence of cervical cancer. You can see where Nigeria is there. Of development of a nation. If you look at that graph closely, you can see that cervical cancer high incidence accurately mapped sub-Saharan Africa, and is a problem. So here, I attempted to compare Nigeria, a developing country, with Norway, a well-developed country. You see the incidence and mortality of cervical cancer. What you have for Norway is the accurate figure, because they have a cancer registry. But Nigeria is estimates, and it's obviously underestimated. Ask yourself, what is responsible for the difference? It's just primary and secondary prevention, which is where we are going. Now, with respect to etiology, cervical cancer is essentially entirely HPV attributable, and it's caused by sexually transmitted high-risk human papillomavirus. There are about 14 of them. The etiological link with high-risk human papillomavirus offers the opportunity for primary prevention with HPV vaccination. That is number one. Then, you know that you're affected or you're infected with high risk doesn't mean you go down with cervical cancer, no. Often you need cofactors like reduced immunity, such as HIV infection or tobacco use, to catalyze the transformation, okay? Now, if you look at this natural course of HPV and cervical cancer precancer, you will see from age 15, a young girl can be infected. That's not a problem. The immune system has the capacity to clear it. So it takes a long time for human papillomavirus infection to become persistent. Even takes a long time for that persistent infection to transform into precancer, CIN. Even at that, it takes a long time for precancer to few of them to transform to cancer. So this offers another opportunity for identification and screening, that is secondary prevention. Even the cancer itself has early stage and late stage, okay? The late stage 2A and below, when identified, can still be cured by radical surgery or radiotherapy, which is still secondary prevention. Now, when women present after that, we can only palliate them, and that is tertiary prevention. We don't want them to present that late. Now, I want to now discuss the global cervical cancer elimination. Given all the things I've told you, the viral causation, the long time it takes for transformation to precancer to occur and the cancer to occur, it presents opportunity to prevent cervical cancer. That's why the WHO took the bull by the horn and developed this strategy, okay? The target here is 2030. And it is historic because that is the first time the world is committing to eliminating a cancer. And that cancer, luckily, is the cervical cancer. It was launched in November 2020, and a few weeks ago, the 4th anniversary was held. And I'm not sure I had any action by Sogon. I plead that in subsequent anniversary that Sogon should do something. The goal of the strategy is to eliminate cervical cancer as a public health problem by the end of the century. Just mark you that elimination does not mean eradication. For this, the point chosen is to get an incidence less than 4 per 100,000 women. That is the cutoff point. And if the world reaches that we say that we've eliminated cervical cancer globally. And there are 3 strategies developed. They call it WHO 90-70-90. Okay? The 90 there means that by the year 2030, 90% of girls 9 to 14 will have been vaccinated. The second one, the 70 there means that by the year 2030, 70% of women will have been screened for cervical cancer, okay, using high-performance tests, at least twice, at age 35 and age 45. And the third one, which is 90, said that by the year 2030, 90% of women identified with either precancer will have been treated, or those identified with cancer, invasive cancer, will have been managed. Remember, I used treated for precancer and managed for cancer. So this is the strategy developed, and I've told you this is the target here is 2030. 2030 is 4 years, 6 years away. This was developed from modeling. You see, it starts from red areas, which has to do with incidence. Remember, I said the darker the red, the higher the incidence. Okay? Now, if nations, member nations, achieve these targets, these 3 targets by the year 2030, and sustain them, by the end of the century, you see what will happen. All the countries will have become very dark blue. And that will mean that we have eliminated cervical cancer. Now, to channel African regions, which bears a large burden of cervical cancer, towards this global elimination initiative, Africa was not keeping quiet. Sajjan, I was told this lecture is supposed to be 1 hour. Sajjan is harassing me. Huh? You know, plenty midnight oil why I born to develop this. If Sogon was paying for it, I'm sure they won't be telling me to round up. Let's highlight one or two. Africa contributes, by then, we were contributing 21% of the mortality. But as of 2020, has increased to 23%. So I don't know whether we are making progress. We don't have national screening program. Our screening program are essentially low performance. And participation in those low performance is so low, less than 10%. Okay? Government do not make any budget, no or low budget for cervical cancer elimination. What they do is they say cancer prevention, which won't work. Now, our patients present so late when we can't do much, and even those that come to hospital for treatment, they spend so much that their families, lose hope and become depressed. So this is just a tip of the iceberg. The problem is legion, okay? Now, this study in Kumasi tried to tell us why our women present so late. Out of 350 patients, 95% of them presented late. It's interesting to know that all those late presenters, none of them had cervical cancer screening. Okay? And so after all analysis and reviews, they found out that income level and rural dwelling are the two major predictors of late presentation, and that can help us in our advocacy and prevention strategy. Now, the framework presented milestones, 2 yearly milestones, 2024, 2026, 2028, under these 3 objectives. And number 1 of them, obviously, is HPV. 4 objectives. Number 1 of them is HPV vaccination, okay? So for each objective, they developed in tabular form what we expect, how many nations we expect to have reached that milestone by that year. Let me give you an example. By this year, okay, this year 2024, the milestone expects that at least 20 member countries will achieve 90% full HPV vaccination of girls 9 to 14. I think we are getting there. That is possible. They now said by this year too, at least 10 member countries will achieve 25% cervical cancer screening coverage. I don't know whether we are achieving that. Then the others, the article is available and we can always look at it. The initiation of routine HPV immunization in Nigeria was a good step, a very good effort by this country. Why? Because HPV vaccination is believed to be the most effective of the 3 strategies. And that's the one most African countries can do. At least we were telling them, let us at least start there. And thank God we've started there. There are many evidence to suggest that it's very effective. One of them I've shown from England. Okay? They started their vaccination in 2008. And they did an audit because they have a register. And they made this conclusion. HPV immunization has successfully HPV immunization program has successfully almost eliminated cervical cancer in women born since September 1995. Okay? They did this review in 2021. So this showcases that vaccination works, and that's why we've been encouraging that. So when Nigeria rolled out the HPV screening, they used a two-phase system. First phase for 15 states and Abuja started in October last year. Second phase for the remaining 21 states started May this year, and they were targeting girls 9 to 14. Then from next year, they want to limit it to only girls who are 9 years of age, hoping that they will have sorted everything out. So you see, the phase 1 are the green states, and the yellow are the phase 2 states. The aim of this rollout, when it was initiated, was to vaccinate 17 million girls by next year, and I must tell you that we have done well. By September this year, Nigeria had vaccinated 12 million girls, which is 70.6%, which I think is a distinction. Okay? So I want to trust the agency, because we know sometimes we collect data under the tree or in an air-conditioned house. So I will wish that Sogon will go to the field and validate this claim. You can just do survey of secondary school girls. It's possible. Now, the next step. I must say here that these are essentially my opinion, but they are well researched and deeply thought of. So, with the nationwide rollout of the routine immunization, it is now critical that we establish a comprehensive roadmap to enhance the program and expedite implementation of the remaining 2 pillars. These steps I've tried to categorize into A and to E. The first one is to enhance the routine immunization, which we've started. You know, there are plenty anti-vax messages, even by doctors and gynecologists. Okay? So we need to do a lot to build trust regarding safety and effectiveness of HPV vaccine, and we should continue to educate parents and the child girl, short-term and continuous. Now we need to, at the long term, we need to introduce a curriculum into the secondary school and the university, the GS, so that young people will know about cancer education. It's important. What students learn in school, they don't forget. Then we need to ensure coverage data published by Nigerian agencies and partners are correct. So this is where M&E, which is the 4th objective of the milestone, is important, and I think Sogon can be part of it. Number 2 is to improve self-reliance in vaccine procurement and production. Last year, the world spent a lot. LMIC spent a lot on vaccine. Okay? They said up to 202 million, multiplied by 1,007. But out of this money, those countries only spent 5%. The remainder were from funders. So the implication is that if there is no funding from outside, we cannot sustain routine HPV immunization, which is a problem. So that is why I'm talking about self-reliance in vaccine procurement and production. A country like India produces their vaccine. I don't see why we can't try something here. The third one is to develop routine cervical cancer screening. Okay? Routine in the sense that the way we now give young girls vaccine, that's the way we are going to give young ladies screening. It has to be free of charge. The truth is that with the ongoing TPN in the country, screening is now down the scale of preference. People don't go screening when they don't feel sick, which is a problem. So how can you get women to screen? Is to make it routine. So that is what we are asking here. We know our problems. The WHO recommends high-performance screening. But what we do essentially here is VIA and pap smear. And WHO has said countries that are still running pap smear can continue till they're able to transit. But countries that are running VIA should quickly transit because it has a lot of quality issues. If you go to the field and see what people report, you will understand the quality issues associated with VIA. So all these problems associated with screening in Nigeria, how can we solve them? And I try to develop to to suggest some implementation that can work. Number one, I've said that we need to make cervical cancer screening routine, just like we've made HPV immunization routine. Who will finance it? The health insurance system should finance as much as they can. Then government should finance the other one. They've removed subsidy in fuel. They need to put the subsidy somewhere. And I think our women will benefit from that subsidy. We must remove out-of-pocket payment for screening if you must work. If we don't do that, payment for screening increases the not my portion syndrome, which I discussed very well during my inaugural in 2019. Now, the second strategy to improve screening is to strengthen the primary health care system in this country. That is the only way we can achieve screening for the women. All these outreaches we do, they are good, but it has been shown that it does not improve health outcome. It cannot even sustain it. And quality assurance is a problem. So, other way to strengthen the primary health system is to ensure that you retain the staff there. You have to improve the salary of the staff at the primary health system. That's the only way you have to drag them from the JAPA syndrome and be able to retain a few of them. Then we need to scale up training of doctors and nurses. I'm restricting the training to those two because they have some basic good training. Those that will be doing the see and treat or see triage and treat. Okay? Then we need to look at our medical students' curriculum. Curriculum has to be must know, need to know, and may know. I'm projecting that the curriculum must ensure that cervical cancer and breast cancer screening should be a must know for anybody graduating from the medical school. Likewise, our residency training, advanced, cervical cancer screening must be a must know. Otherwise, they shouldn't pass. So that's the way to ensure that these things are scaled up as quickly as possible. Then the third strategy is to develop a registry. Abroad, women are invited when due to come and screen. That is possible here. Everybody has a phone. And the telecommunication companies can use their corporate whatever to help in this. Women are responsible. If you make it free and you invite them to come, they will come. I believe that. Now, to scale up cervical cancer, pre-cancer treatment, you see, when you screen and you can't treat, it's unethical. So you cannot, the both of them go hand in hand, training on screening and then training on treatment. So I recommend the see and treat and see, triage and treat approaches. Both approaches can still be achieved within a single visit approach. These are WHO 2021 and 2024 guidelines. Okay? That is why we should target ourselves. The see and treat means you just screen, you use a test, and if the person is positive, you treat her. The see triage means you have to do two tests, the screening and the triaging test, and there must not be histology. Okay? On the right, you can see how they are itemized, and I recommend algorithm 2 and 4. I will show you what they mean. Algorithm 2 is just see and treat. HPV screening, if it's positive, treat. If it's not positive, she comes back. Algorithm 4 is HPV screening. Then the triage test is partial genotyping. So the HPV DNA screening you must do here should be able to distinguish between someone who has HPV 16 and 18 and those who have others. Okay? The algorithms are clear. You can look at them. The first strategy is I'm rounding up. Okay. Following this, I think the Sogon has a guideline on cervical cancer screening, which I think needs urgent updating. Okay, it's essentially old. Now, we need to scale up cervical cancer screening. cervical cancer treatment. The early stage, we need to treat, we need to do radiotherapy or radical surgery. Then the last stage, we need to do palliative and radiotherapy. You can see the different stages there. The problem with treatment in Nigeria is suboptimal surgical capacity. Many people do radical hysterectomy or claim to do radical hysterectomy. Meanwhile, they are doing simple hysterectomy. It's a problem. Another problem is the radiotherapy. So this suboptimal surgical capacity, what has Nigeria been doing to sort it out? One is that the colleges have started subspecialty training. Okay? This is an advert from West Africa. Okay? National has equally started. But the truth is that these are in the infantile stage. And as much as I can say, is a long-term approach. It will not help us achieve the milestone. The second method is the International Gynecologic Cancer Society Global Gynae Oncology Fellowship. We have 4 centers in Nigeria. It started in Enugu, and the local supervisor is here, Professor Chibu, who will speak after me. This program is a 2-year program, and it's working. Unfortunately, since 2019, when it started, 52 fellows have graduated, none from Nigeria yet. So you can see it will not help us in the immediate term. I think is a long-term thing. There are other strategies. One is Gynae Oncology Observership, which some of us go abroad to do. You just be watching them. Watching and doing are not the same thing. When you come back, your head will scatter. Nobody will guide you again. Then the third one is a distance training, online lectures and video conferencing. There's one that is ongoing between MSKCC and AGO collaboration. The leader is here, Dr. Ibrahim, and it goes on every month. So what I'm saying that all these efforts are good and need to be further developed and expanded, but we need an urgent stopgap to achieve the African milestone. So what is that stopgap? It's focused surgical intensification program, okay? It's an innovative and competence-based program developed by some African Gynae Oncology Group. They tried several models in different African countries till they were able to get this model in Zambia. The program is focused on experienced gynecology oncologists, training the generalists at home on specific surgery, which is radical abdominal hysterectomy and bilateral pelvic lymphadenopathy only. So it's based on doing plenty cases. It's focused because it's focused on those surgeries because they mobilize a lot of cases at a time. So within 6 months, someone develops proficiency in this particular surgery. So if you now want to go and do complete total Gynae oncology program, that's okay. But our interest is to be able to treat women whom you are deeming to have early stage cervical cancer. If we cannot do that, we are doing the service to the women. So I presented this with what they did in Malawi. You can see the objective is just to rapidly teach radical hysterectomy and pelvic lymphadenopathy for early stage cancer. That's the objective. I say any other advanced surgery, no, they didn't do any other thing. So within 6 months, they mobilize you, train you, and you can comfortably do this surgery. And this is what I think we need now while we expand the other programs. They had a problem when they were doing this issue. And that problem is that in South Africa, when they were trying to develop the model, and thus they were unable to bring in the degree of focus to the training seminars that were required for the effective skill transfer. I'm just wondering what will happen if we start it in Nigeria. So further intervention, I'm rounding off. Further intervention to improve advanced cervical cancer treatment, we need more functional radio-oncology centers. All the PPP centers, they need to look at them again and make it more affordable. We need to expand our existing cancer fund and improve the ease of access. There's no point saying you have fund. Now to access it becomes a problem. We need to strengthen our histories for both the secondary and the tertiary health facility. Then we need to manage cervical cancer elimination strategy with improved interest in cervical cancer by all tiers of government, we expect this kind of letter that will appoint SA info. It's only them that can do that. Remember, our government officials, others, they don't answer phone. If you write them email, they won't answer, except if you are writing from abroad. So, but I'm sure if Sogon does that, they will listen, and then boys will come in to mobilize. So in conclusion, cervical cancer burden in immunization we've established and is